Greetings and welcome to AWHONN Insights, the home for candid nursing conversations. Today, we are so excited to welcome Dr. Nicole Rankins, a practicing board-certified OB-GYN with over 20 years of experience and thousands of births attended. I'm your host, Bria Anopise, and I'm joined by co-host Jessica Idawali, Director of Collaborative Programs at AWHONN.
Thank you, Bria, and welcome, Dr. Rankins. We're so excited to have you. And
thank you so much. I'm excited to be here.
And I'm a big fan of your podcast. And
thank you.
I'm so glad to introduce it to our listeners. So do you want to just kind of tell us what your podcast, Birth with Power, is about and why you decided to create it?
Sure. So, and feel free to cut me off if I start talking too much. So it's Birth with Power is really about helping women have a great birth experience, specifically in the hospital. And I started it, it's been a little over 5 years, almost 6 years, because I noticed that there was a lot of information, like people were going to Google. It's hard to believe that only 5 or 6 years ago, it was like Google. And now obviously it's a whole different landscape in terms of where people get information. But back then people would go to Google to look for things, or even a little bit on social media. And I didn't see voices that I felt like were presenting evidence-based information in a way that wasn't swaying people. I'm really about giving people information and helping them make informed choices for themselves. And I actually started a blog at first, and then writing on a regular basis was challenging. And I am a big podcast fan junkie. Serial season 1 got me hooked on podcasts, like the best podcasting series ever. If you haven't listened to it, listen to Serial season 1. And then I just looked into what is it like to start a podcast? And it turns out that it's actually pretty easy. The hard part is continuing it, but starting a podcast is not very difficult. So I just started recording it right here, where we are sitting at my desk. I still record at my desk, nothing fancy or anything. And it just grew over time. Now it's been downloaded 2.8 million times. So
wow, that's fantastic.
Yeah.
I know I came upon it because I was searching for podcasts, and before I want to ask a couple of questions before I talk about some highlighted videos. But even with the background that I have in high risk critical care, I'm learning so much that I think patients should know. And I really want to talk about how we can utilize it. So from your perspective as an OB-GYN, how do you see the nursing role shaping patient outcomes in pregnancy and birth?
Yeah, so specifically, and I should say I'm an OB hospitalist for the past 6 years. So that's a lie. It's been longer than that. It's been like 10 years. I've been 6 years at the hospital where I am now. So I only work in the hospital on labor and delivery. So 99% of what I do is pregnancy and birth. So I'm going to speak specifically about labor and delivery nurses, and just a critical role. I mean, we cannot do what we do without the role of great nurses at the bedside. It's so important for us to advocate for appropriate staffing ratios. So because the nurses are the ones who are there, physicians typically are in the office, or they're off doing other things. So I can't overstate how important it is to have great collaboration with your labor and delivery nurses, and of course, postpartum nurses, and then the NICU and neonatal side as well. But for me specifically, I love a great labor and delivery nurse. So important. And for patients specifically, I think they don't necessarily realize how, until they're in it, how that's the person who you're really probably going to see the most and often bond with the most during your labor and birth experience. And they are a bit of a gatekeeper in terms of the information that your doctor receives and the way it's presented, and can help shape and color the course of your birth. There's one way to say, oh, she hasn't changed, but her cervix is a little thinner and the baby's a little bit lower, and I'm feeling optimistic that if we keep going, or maybe if we try a little Pitocin, things like that. A labor and delivery nurse can play a huge role in helping shape birth experience. Just so important.
Thank you. Yes, I agree. I think the bond between OB-GYNs and their nurses and how they communicate and how they tell the patient's story is pivotal to the way the
Mhm.
patient's labor progresses, or if, they see anything that might be of clinical significance, like any clinical changes. I want to talk a little bit about some of your episodes because I've been, part of my New Year's resolution is to walk almost every day. And so part
Okay.
of that, I listen to podcasts. And so I recently came up to one of your episodes that it's a postpartum replace. I believe you
Mhm.
recorded it before, but it's coming
I
back
did.
up, and it's
Mhm.
recognizing when you need maternal health support. And you had
Mhm.
Dr. Stephanie Waggle.
Mhm.
And I just learned so much about it. I think many people still think postpartum depression only happens right after birth. Can you explain the true time frame of postpartum mood and anxiety disorders the way Dr. Waggle described it in your
Sh-
episode?
Sure. I mean, it can really happen up until a year after birth. But to be honest and truth, we actually need to think about it in the pregnancy period as well. I personally found so many more women and birthing people coming into the experience with anxiety, with depression, because of the heaviness of life. Really, it's difficult. Things are challenging, and then social media doesn't help, things like that. So it's really even into pregnancy and then postpartum and really up to a year postpartum that we really need to be thinking about not just mental health, which is very important, but of course, physical health. I mean, we know in our country we do a terrible job of taking care of women in the postpartum period, but it's so important to think of it as for sure at a minimum in that first year after birth.
And and Dr. Waggle also spoke to, I think she provided some statistics, but one of them was including the partners, and she said something about 1 out of 10 men also experience postpartum depression or anxiety. And the other thing she talked about, and I don't want to spoil anything about the episode, but she talked about the differences of medication uh, that you can be prescribed
Mhm.
postpartum. Do you want to talk about any of the key takeaways from that?
Sure. I would say the biggest takeaway that we all need to realize is that you can't take care of your baby if you are not healthy. So I want you to know that first, that prioritizing your own health, including your mental health, is so important. So if you need to take medication, then don't be afraid or worried because, again, for your baby to be most healthy, you got to be healthy. So typically we start with like SSRIs, that category of medications, Wellbutrin, Zoloft, Prozac. There are lots of different options there. I think we underutilize therapy probably, and it can be difficult to do therapy because of the time constraints, but sometimes just talk therapy can be helpful as well. And then there are newer medications to help with postpartum depression. I don't have as much experience with those, and my colleagues neither don't have as much experience with those. So that can be, they're like one shot, one dose medications that can last for a longer period, but they have been shown to be pretty effective in helping with postpartum depression. The other thing I will say, which is also challenging, is that your OB probably doesn't know a lot about that long term management of postpartum depression. We can get you started on some medications, but you'll need to connect with a therapist or mental health professional who can continue that for the long term, or maybe your primary care doctor who feels comfortable with that. And it's actually really important if you're concerned. It's best to identify someone before you give birth so that you have that resource ready and available. So just so much there that we can do it. So many options. I just want people to know they have options and things that they can do. So I would say emphasize to folks that um, just seek help, and that there's nothing wrong with seeking help. And that doesn't mean that you don't love your baby. Sometimes it's just hard having a baby, and that's like a normal part of becoming a mother.
Yeah. Yeah. And I believe also, I think Dr. Weigel was a reproductive psychologist, right? And so,
Yes, a reproductive psychiatrist, which is rare. So she did additional training. So she's a physician trained as a psychiatrist who did additional training specifically in reproductive medicine. That is not an easy thing to find. If you can find someone like that, then that would be great. I believe she actually does some online things, telehealth sort of things. So that's an option as well.
Yeah. Thank you. The other episode that I wanted to talk about, which I found super fascinating, you had a guest, I think, I'm trying to remember her name,
Oh,
Alexandria.
Alexandra.
Yeah. And it was about informed consent isn't formed consent, it's a conversation.
Yeah.
We had some key takeaways that I think nurses can really learn from that episode. Do you want to tell us a little bit about them?
Okay, this one I can yap about for a long time. So, the first thing I will say is that honestly, when Alexandra, but like I was on her podcast and I invited her on mine, I was like, I don't know how this is going to go because our audiences are different. Her audience leans anti-vaccine, anti-medical in a way. She believes one of her children was injured by, I want to say she said vitamin K so we kind of have different perspectives on things. But what this opened me up to is that when we had a conversation, we actually had a lot in common, and that we just wanted people to have good information to base their decisions. So when you're a nurse at the bedside and you see someone who may be like, they're like, well, I don't want this. I don't want that. This sometimes it's from a place of like not knowing good information, and it is worth a try to help have that conversation, because you'd be surprised how you can connect and do it in a way that's not confrontational or adversarial. Just have a conversation about things. I found that social media and the media is going to promote the extremes, people who like hate stuff, or people who are like, if you don't do vaccines, you're a horrible person. But the reality is that most of us are in the middle, and we have reasonable questions, just want some reassurance. So if you have that opportunity to connect with someone who you think may be different than you, please take it. So that's the first thing that I would say. And yeah. And then the other thing that I would say is, we all know this, but I think we need to be reminded sometimes, consent is not a piece of paper. The piece of paper is actually like the piece of paper is a hospital requirement kind of thing that somebody signed it. Consent is really a discussion, and it really should be a conversation, and it should be an ongoing conversation. And I realized in the way that I practice and how I had to change the way that I practice is so much of what we do is like, we just sort of do it a little bit of a patriarchal approach. And people interpret that to mean like, oh, the doctor's going in there and they're just sort of telling you what to do, and in a sort of mean way. But that's not how it goes. Like, for example, could go into a room and say, hey, I'm Dr. Rankins. I'm just here to check your cervix. If you can just put your ankles together, let your legs relax out to the side. You're going to feel my 2 fingers, lots of pressure. And in all of that conversation, I was very nice, but at no point did I explain why I was doing it. I did not ask her first, is it okay if I do it? I did not ask her if she has any questions about anything. Didn't ask her, maybe does she need to go to the bathroom before we even start doing this exam? So it's so important for us to step back and really center that person. And it's really not that hard. Some people say, oh, it takes all this time, all that's extra time, and I'm running from the office and I got to do this and that. It takes 2 seconds to say, I just want to check and see what your labor progress is like. Is it okay if I do the exam? Then be okay if they say no, because that's also okay. And then offer them some opportunity to ask questions and say like that it's something to go forward with. You're building that trust and working together. I would say that's one of the number one things that I had pregnant folks say to me a lot, is that people just come in and they just do these exams, and we misinterpret people not pushing back against it as them being okay with it. But I think especially as women, we're often conditioned to just sort of go with the flow, and we hold that pain in internally. And there's some things that we can do that are very easy as physicians, as nurses, to make it a more appropriate experience.
I'm glad you bring that up, because that's a good transition to utilizing your podcast from episode 306, tracking labor progress and vaginal exam decoding, how you spoke to the patients on that episode, or approached vaginal exams, and including it in your informed consent, because it's also how you talk to the patient, how you present it, and how you demystify it. Mm-hmm. You want to talk a little bit about that episode?
Sure. Yeah. So this is just something that I think there's a lot of misunderstanding about with vaginal exams. I think it's very easy for us to get sort of into the flow and the groove of things. We're just kind of going along. And it's really important that we need to remember that the person in front of us has probably done this once, twice, maybe three times, whereas we've done it hundreds of times. And so some things need to be explained. So a few things that are important are, of course, again, like I said, asking consent is just it's so easy and it's so necessary and should be a standard part of care. I know a lot of people talk about like trauma informed care, which is really important. I hope somebody's probably going to flame me for this. I actually dislike that term or dislike that we've talked about that type of care only in reference to trauma informed care. That should be the care for everybody, whether you've had trauma or not. So really just asking, centering the person's needs, and then helping people understand that I often will say, like, we don't have a ruler in there when we're doing a vaginal exam. So just remind people that it's an estimate and that please don't get discouraged because one person says you're 3 centimeters and someone else says you're 4 centimeters. There can be variations in the exam that are totally normal. I also think it's important to explain that this is a single data point. It does not predict how long your labor will go. It does not predict exactly when you're having your baby. It's just information, and it's something that we gather over time. So it's what we have at that moment. We put the big picture together of how things track over time, and we use that accordingly. I think the biggest places where I see folks, women get frustrated is if there's slower progress and they get concerned. So I think there's definitely a role for the nurse to offer some reassurance, especially for like a labor induction or things like that things just take time. And another thing I would say is we all have to be okay with if people decline an exam. Unfortunately, we're not that trained in other signs of labor progress. And it's harder when folks don't have an epidural. You can't as necessarily see, the body clues, but we need to be okay if somebody's like, well, maybe I want to wait a little bit. I'm just not ready right now. Also, okay. Like we need to create that space that it's that person's body, it's her body, and she makes the choices around it. And we have to be okay with that.
What kind of language, thank you for that. What kind of language and communication strategies would help nurses explain why about dilatation and effacement and station so that patients can remember?
Yeah, so this is an interesting one because I've actually found that some people say the exam numbers in a different way. And so it's important. Like some people say effacement, then dilation, then station, whereas I was taught a certain way. So it's very interesting that you'll find little differences in the way people do things. I would say just try to present it in the most straightforward kind of way. You can even show them like this is about how dilated your cervix is. And then effacement is like the cervix is kind of like a tube, and as the labor progresses, that tube just kind of gets smaller and smaller and thinner until it feels like paper. And that one people seem to understand. And then I've never found that like some people compare it to like fruits and things like that. I don't know that I've necessarily found that particularly helpful. There's always also that little board. I'm sure we've all seen on labor and delivery the little thing. Yes, so you can also show that. Yes, you can also show that to patients. And then station is always the one that I feel like is most complicated because the anatomical definition is the relation of the baby's head to the ischial spines. And people are like, well, where are those? Like, I'm still trying to explain that to them. So I just say that it's where your baby is in your pelvis. And the further down your baby is in your pelvis, the larger the numbers get. And they go to 0, +1, +2, +3, or some people go to +5. And that seems to help people understand.
Thank you. So you talk about hot topics, like for instance, I'm going to go back a little bit about informed consent, or and I was shocked that you had Alexia on, but I learned a lot. And she talks about talking to patients about reading all the patient insert or all the medication inserts
Yeah.
and kind of what that really means. But she did it in a way that, like you said, is not adversarial. One of the hot topics that you bring up on episode 299 is how to protect your power and avoid an unnecessary episiotomy. As you know, episiotomies aren't routine anymore yet. Some hospitals, they currently persist. I talk a lot with my hands. I'm sorry. So what role can a nurse play in real time to advocate without creating conflict or adversary when they think that episiotomy may be performed?
Sure. So I know it can be challenging, but I believe it's okay. And it's not that difficult to remind your patient that before an episiotomy is done, there should be a discussion about it, and your doctor should ask you about it. I've had nurses who if they know that the doctor does a lot of episiotomies, they kind of say, you might want to ask about what they do with episiotomies the next time they come in the room, just so you know how things go. So that doesn't necessarily throw the doctor on the bus or under the bus or create conflict in that kind of way. In the extreme cases, I've seen nurses kind of discreetly move the scissors to a difficult place or call on the table or call the doctor at the very last minute so there's no time to cut an episiotomy. But it's really just like opening the conversation to say, it's okay if you ask or if you have concerns. If somebody has a birth plan, read the birth plan. And then if they mention episiotomy, then that's a great opportunity for you to follow up with it as well. That's something that I always do, is sit down at the bedside, go through the birth plan with the patient and the partner. And, we can talk about any things that come up and provide reassurance that, I can't remember the last time I've done episiotomy, or, if I do, I'm going to ask beforehand. I will say something that we don't realize, or people accept, is that they think, well, what if it's an emergency? I can tell you there is always time to ask people for consent. It may take 15 seconds, 20 seconds. Your baby's heart rate is low. I need to make a cut in episiotomy to make a little bit of extra space because your baby's heart rate's low and needs to be born now. Is it okay if I do that? And I've never had anyone say no when I explain it like that. So just kind of getting rid of this, well, sometimes it needs to happen, or we can't do consent. That's not true. And I would say another role is if nurses can get active in committees, or if there are things where we talk about episiotomy rates and bring it up in a collegial fashion, then that can help also. Where I work, we have what's called a collaborative committee, which is OB, peds, anesthesia, and the practices. And we talk about, in nursing, of course, and we talk about these things and the numbers and things like that. So having that sort of collaboration can be really helpful too.
Yeah. What other strategies can nurses partner with providers, or techniques to reduce? Yeah,
sure. Of course, warm compresses. I'm like, oh yeah, what about it? Warm compresses can help for sure. And I know it can be challenging because you got to keep the water warm, and people have different ways of being creative. Sometimes doulas will bring in a little hot pot of water, and we're just sort of using that. So you can do warm compresses. We use a ton of olive oil. So while folks are pushing, you can use olive oil. Different positions, or supporting people pushing in positions that feel most comfortable for them, is important. So I think those would be the biggest things.
So you mentioned having a birthing plan. And one of the things that you talk about on your web, or that you offer on your webpage, as far as resources, is a birthing plan for patients. What's the difference between your birthing plan versus a normal birthing plan that you would see? What?
Yeah, so I actually teach it as a class. It's something that I'm going to bring back. I'm just a little bit on hiatus of it. Is that one, you can't plan birth. So that's the first step I say is like, I know I call it a birth plan, but don't say that anymore. It's actually birth wishes because birth cannot be planned, or birth preferences. So I say birth plan because that's what people say, but I can't plan. When you have a doctor that says you can just come in, you can get induced, things are going to go like this. They can't plan that. I can't plan your birth. You as a person who are pregnant cannot plan your birth. Your baby decides how they're going to come, and they don't tell us what they intend to do. So we ride with their plan. So we can't plan birth. That doesn't mean, of course, that you can't have wishes, preferences for how you like things to go, but you have to be flexible and you have to be open. So those are the big important things. And then probably the most important thing I emphasize about a birth plan is that if you are waiting to give this piece of paper to the nurse or the doctor at the hospital, that is entirely too late. Mm-hmm. Filling out a form, and that's a great start, but this really needs to be a conversation that you have during the prenatal period, when things are calm, when things are, we're just talking and you're not in the throes of labor. And then you know that they support the things that you want. Nothing is worse than getting to the hospital and you're like, well, I want to be able to get up and move around. And they're like, well, that we don't do that here. So you just have to have those conversations ahead of time. That piece of paper is the last stamp, and it's just sort of a seal, like the final thing to say, okay, I've already talked about these things and I feel good about these things. And people underestimate the importance of when you already go into your birth experience feeling supported and like you kind of know what you're going to expect. Mm-hmm. And all of us helping create that atmosphere of that person feeling safe, that person feeling supported. It helps the physiology of birth, and it helps the body to go through the birth process better. I'm sure everyone who's listened, you've seen the instances where if someone is truly terrified or really scared, you can, mainline Pitocin, you can replace their blood with Pitocin. There's nothing's going to happen because they're so scared and they're so terrified, and their body will literally shut down. It's a physiologic response. If you're scared, you're going to shut down the labor process. Yeah. So just really helping to create that safety. And I encourage all of us to read through the birth plan with the patient, to offer them reassurance or offer them how things are done at that hospital. It just helps set the stage so much better.
Yeah. And if anybody's ever taken like a fetal heart monitoring class or or any of our other classes, it talks about maternal catecholamines and how to reduce them and try to, ease that. I also want to talk about, because I think it's really important what you said, talk in the prenatal period, talk with your doctor, ask what to expect, do the tours. And with that, you also have another guide on your website, which is Your Doctor Right for Your Birth. It's a free guide. You want to tell us a little bit about that guide that I think most nurses should use with their patients?
Yeah. So it's really just helping make sure you and your doctor are on the same page about things and how they approach birth. Are they, and everybody has a different perspective about how they want to do things. There's some folks who want to have a primary elective C-section. That's fine. That's what you want to do. But if you want to have more movement or intermittent monitoring, or you not necessarily want an induction, or you just want to kind of know how your doctor approaches birth. How do they work with doulas? If you're interested in getting a doula, they're just questions to help you know that you are on the right page. And it's gathering information. It's not adversarial. It's not like, you better do this or you better do that. It's just to help you know, are we clicking? I have seen time and time again where people were like, this didn't feel right. Something was off. That's my last thing. Like, what does your gut tell you about this person? And then they regret not changing. I have not seen anyone regret changing if they felt that was the right thing for them. So that's really just to help make sure you're on the same page. Trust and collaboration is just so key when it comes to pregnancy and birth, because we all know that in this moment, things can go from 0 to blank and stuff is hitting the fan. And when you have that trust, you can walk folks through that journey with, it's just easier and without them being so traumatized from it, because they know that you're looking out for their best interests.
Yeah, it's one of the most vulnerable experiences that you can have in your lifetime as somebody that has birth. So I believe like picking the right, and we do so much research for other things, like other like products, and like why would you should research your physician, make sure that you guys are on the same page and make sure that it's exactly what you want. There's nothing wrong with that. And I think
at all
giving people permission to do that, I think is also amazing. The last guidebook or resource that I wanted to talk about that I also read through is your labor pain management playbook. You want to tell our listeners a little bit about that?
Yeah. And just to back up for a second, I have a doctor guide and then questions to ask on the hospital tour. And the reason you have to do both is because the way modern obstetrics is done, it may not be your doctor at your birth, maybe a different doctor. So you need to know that. And you need to know the hospital where you're giving birth. Those are the two biggest influences on your birth experience, where it happens and who's there. So just making sure you understand that is really important. So you got to do both. And then as far as labor pain management, it's just really to give people their options and help them have a realistic picture. So for example, and I will say is to help people prepare. Like I've only seen a handful of folks walk in and say, I'm going to do an unmedicated birth with zero preparation. And then that actually happens. So it's just to give people some things to like prepare and know what tools are in your toolbox, what you're comfortable with, what you're not comfortable with. Like, does the hospital have showers, tubs? Are they supportive of you walking around? Do they have wireless monitors so you can move? Because movement helps with pain. So it talks about the techniques for if you don't want to use medication. And then, and I don't use the term natural birth because all birth is natural. I mean, you're growing a human, that's nature. How the baby gets here or what pain management you use doesn't affect that nature piece. So it's either with medication or without medication. And then people have a misunderstanding about nitrous oxide and IV pain medication. And I'm honest that, look, those can be great adjuncts to sort of take the edge off, but they ain't replacing the epidural, and we need to be clear on that. Okay. Like, so don't think that this is going to do the same thing, because it's not. So just letting them know that IV medication is a temporary thing, that it crosses the placenta. It will get to your baby. Your baby will clear it like we do, but it takes longer. So helping them know those things ahead of time. And then nitrous, I feel like it can be hit or miss. So letting folks know that, or your hospital may not have it. Some hospitals don't have nitrous at all. And I would say the biggest one that I see for epidurals is the surprise, the shock, the pain, both mentally and physically, when it does not work as expected.
I know.
That is the one where it's like, people like, what is, I don't understand, where it's either one-sided or it's not giving the relief or it has to be redone. People can be very unprepared for that. And although that is not likely to happen, you have to be aware, because otherwise it can really, really throw you off if that happens. Epidural is not guaranteed.
Yeah, which is why I love your episodes. I love your free resources. I think, we cater to a lot of nurses, both in clinic and both labor and delivery, postpartum. And I think, if you know that these exist, which is why we wanted to bring you on so badly, is that please, share this with your patients in clinic. Let them hear this on their own time so that they can get this valuable education. Because like you said before, it doesn't sway you either way. It's just information. It's the best patient for me is an informed patient, because if they understand, for example, that epidural may not work? What can we do for you? How can we fix it? Or that we have to redo an epidural, right? Because
Right.
sometimes they have to redo the entire thing.
Yep.
It's like, really?
Yeah.
8 centimeters, I'm in pain. You have to redo my epidural.
Yeah.
But if they have that information beforehand, it's not such a shock. It's not as, it may be traumatic, but not as traumatic because you have
Exactly.
the information. So I just really appreciate you coming on here. I really appreciate your podcast. I think it's great for, well, I just thought for patient information, but then when I listened to it, I was like, oh my God, I'm learning so much. So of course I want to keep on listening because you just have such valuable pearls of wisdom. So anything that you want to say to the listeners before we close up for today?
Well, thank you for those kind words. I really, really appreciate it. And thank you for all of the work that you all do at the bedside. I mean that from the deepest part of my heart. We cannot do what we do without strong labor and delivery nurses, without strong nurses in the clinic, without postpartum nurses. Your job is invaluable, and please keep doing what you're doing. I love you all.
Thank you. Thank you for being here. And we love you all too. I mean, we can't work without collaboration. So we just appreciate you coming by.
Yeah.
Thank you so much.
Thank you.
Dr. Rankins, we're so delighted that you joined A1 Insights to share how our listeners, many of them who are L&D nurses, can empower their patients before, during, and after birth, as well as educate themselves in their clinical practice. And Jessica just gave us her testimony. You have such caring approach. You center the patient. You have great insight. So we see why you have a top 50 parenting podcast with over 2 million downloads. And we can say that we certainly want to get to where you are with the trust that you've built with your audience. For all of our listeners, we encourage you to use both of our podcasts, Birth with Power and A1 Insights, because there's a wealth of information there within your reach. To take advantage of the resources that we've talked about today and to read Dr. Rankin's bio, you can go to our website at a1.org/podcast. Be sure to subscribe to A1 Insights on multiple streaming platforms so you can catch up on any episodes that you've missed. You can also follow us on our YouTube channel. Please recommend this episode or any of our episodes to a friend or colleague. And feel free to leave a comment or send us an email at podcast@a1.org. Thank you all again for your time and attention. Thank you, Dr. Rankins. Thank you, Jessica. Everyone, please be well and stay safe.